Christine, another day for us.
Yeah, here we go.
Today, I thought I would pick circulatory system and blood to talk about. How does that sound to you?
That sounds fine with me.
Do you have blood? Like, is that something that you have? I know we talk about a lot of conditions. We don't always have conditions. Do you have blood?
You're hysterical. Like, do I have a stash here?
Yeah, well, you might. You're
No.
with all of your endurance training, you might.
Yeah. No, I don't need that.
All right, enough joking around, Christine, will you?
Mm-hmm.
All right, so first up, anatomy and physiology review. I love these couple of pictures. I stole these from the Body World exhibit. So if anybody has an opportunity to go to one of those, it's pretty incredible how they have human cadavers and organs throughout. They're really fascinating. Have you ever been to that, Christine?
Yeah, I have been to that. It's really, really cool to see, but I haven't been since it first opened. And
Yeah.
so I would love to go again. And now that I know so much more about the body.
So blood circulates throughout the entire body. All of the body systems are dependent on blood, and the blood is going to function to bring oxygen and nutrients to the tissue, bring waste products away from the tissue and be circulated and excreted from the body somehow. And it plays a critical role in the body's defense and immune system. If we think way back to week 1, we talked a lot about the immune system. So the blood vessels themselves, arteries, capillaries, veins, that's a closed system to circulate the blood. The two major exchanges of the blood are the pulmonary circulation, which allows carbon dioxide and oxygen to be exchanged within the lungs. And then there's the systemic circulation, which now we're bringing the nutrients and wastes from the body, the cells of the body, and then back away from where it originated from. So overall, the system flows from the larger blood vessels, the arteries. We go to the smaller vessels, the arterioles, and then the capillaries are the smallest structures where there's exchange. That's where all that exchange between oxygenated and deoxygenated blood happens. We're going to go to the small venules and then into the larger veins. Around 70% of our blood is located in the veins at any one time. And the blood flow through the veins depends on skeletal muscle contraction, respiratory movements, and then gravity. So if someone's at risk for blood clots, we'll talk about later, the big things that we try to educate our patient on is, one, contract your muscles. Even if you're laying in bed, just doing slight ankle pumps, quad sets, glute sets, just this muscle contraction will help with venous return. Also, gravity. If you think about your legs, if you elevate the leg, gravity is helping pull that blood back towards the heart. So a few things we talk about just automatically. Now, within the veins, we do have these little valves that help prevent backflow in the veins, because you can imagine if we're more vertical orientation in these veins, the second the heart pumps, we get the blood a little further away, but if there's no valves, it'll continue to backslide down. And we'll see some conditions where the valves within the veins can be a problem. Some anatomy review that you probably learned back when you took either anatomy 1 or 2. We have the different layers of the blood vessels. You can look at that on your own. I think the ones for us to understand is the inner layer of the blood vessels. The endothelial cells make up that layer. And when those get damaged, then we get things like plaque buildup, and we'll talk about some conditions for that. So those endothelial cells are trying to be really smooth, and when they're not, that's when we can start getting some coagulation or some buildup of different plaques. Arterioles and can vasodilate or vasoconstrict depending on the need of the area. So they increase need. They would vasodilate to allow more blood flow in, vasoconstrict if it needs to reduce the amount of blood flow into the area. So blood is the major transport system of the body for essential things like oxygen, glucose, other nutrients, hormones, electrolytes, cell waste. Also carries our antibodies and white blood cells of many different kinds of white blood cells. It also controls homeostasis to help regulate body temperature. I think we can see that on cold days when we go outside. Why does our face turn pink on those cold days? Well, because the body's driving more blood flow to the exposed skin, and that's why we get that. So that's an example of how it regulates temperature, regulates fluid levels, blood pressure, different clotting factors. It also maintains the stable pH of the body. So the body has about 5 liters of blood in it. 55% of it is plasma, that's water and dissolved solutes, and 45% of the blood is composed of cells or other formed liquid elements, white blood cells and platelets. So erythrocytes are the majority of cells in the blood, functions to transport oxygen on hemoglobin. So those are red blood cells. Leukocytes, about 1% of the blood volume, our white blood cells function for the body's defense system, neutrophils, lymphocytes, eosinophils, basophils, monocytes, all important for the body's defenses to fight off different infections or foreign bodies. And then platelets help function to clot the blood when we need. So oftentimes we look at hematocrit, especially if we're on the inpatient side. That's the percentage of the cells or the red blood cells or erythrocytes in the blood. Indicates the viscosity of it. Higher hematocrit could be because of dehydration, low hematocrit, blood loss, or anemia. In males, between 42 and 52% of the blood should be red blood cells. So hematocrit, 48% would be normal. For females, slightly lower, 37 to 48%. So the big reason for a lot of our students here is the importance of understanding hematocrit, because exercise is contraindicated with a hematocrit less than 25%. The blood just is not exchanging enough oxygen to and waste from all of these active cellular areas. So if we add the demand of more oxygen with exercise, well, there's not enough red blood cells carrying oxygen to those working tissues. We can do exercise with caution at 25 to 35%. So this is one of those things where if we have a patient that's indicated with a condition that would affect hematocrit, we will be checking their hematocrit before every single time we do PT, OT, or massage with them. So the red blood cells originate in the red bone marrow, found in flat irregular bones like the ribs, vertebrae, sternum, pelvis. That's where the red blood cells are coming from. Any other ways we can recognize and see where hematocrit is important in the world, or where we see real life?
Yeah. So hematocrit, if you've heard of with, for example, cycling, but it definitely comes up in other sports as well, but professional cycling, Lance Armstrong ran into some trouble before he retired because of blood doping. And so blood doping basically in sports is meant to raise the hematocrit level. And the way that this is done is that either people will inject themselves with artificial erythropoietin, which is EPO. Maybe you've heard of EPO, and that raises the hematocrit level, or they will have some of their blood removed from their body. It'll be put in a centrifuge and then put back in so that there's a higher number of red blood cells. And that will also raise the hematocrit level. But you can imagine the dangers in doing that where people who are not healthcare professionals. And so this is what blood doping is. And the International Cycling Union, their hematocrit limit when they do testing for blood doping is anything over 50% for men. They're not able to compete. And so what I think is also interesting is those are the illegal ways in sport to raise hematocrit level for performance. Hematocrit level can also be raised by training or even sleeping at altitude, say at 9,000 feet. So that's why a lot of athletes maybe want to live in Boulder, Colorado, different places where they can train at altitude, because that can raise hematocrit about 2 to 3%, and it really makes a difference on performance. So yeah, I think that is interesting.
Yeah, more red blood cells transports oxygen more, and especially in endurance sports, man, that's everything.
And it just gives you like more oomph to your muscles.
Yeah. Yeah, and at altitude, the reason the physiology between why that increases hematocrit is because there's less oxygen in the air at altitude. So to make up for that less decreased oxygen just in atmospheric air, the body produces more red blood cells automatically as a counter to that. So yeah, pretty amazing.
When I was doing competitive racing about back in the day, I was sleeping in an altitude tent. And so it was this big plastic bubble that fit my whole bed in there. And it would zipper closed and seal. And I was sleeping at 9,000 feet. So there was like the oxygen machine that you would see that you connect for your patients in the hospital. It was set to a reverse setting so that it took oxygen out of the air, and that's how it got to 9,000 feet.
Wow.
In the tent.
Those reverse buttons aren't on our patients' machines though.
Right.
we don't want our patients to accidentally press the reverse button on it. So yeah, they don't have it. It is a similar but different machine.
Right.
What kind of racing you talking about? Speed walking?
Yeah, I'm the speed walking champ. No, this was triathlon.
Oh, okay. I gotta tell you, speed walking is kind of funny to look at initially, but man, that is really tough to walk that fast at that distance. That
It's
is
hard.
no joke.
Yeah.
Anyway, let's get back to work. We got to talk about the pathologies next. So first one we could talk about are different anemias. Anemias reduce oxygen transportation due to the decrease in hemoglobin content. So again, hemoglobin is on the red blood cells. That's what oxygen binds to. If we don't have enough hemoglobin, then the oxygen isn't binding to the red blood cells, even if the red blood cells are abundant. If there's not enough hemoglobin, then the oxygen is just not going to be transported. So it could be a result of declining production of protein, the decrease of the hemoglobin protein, a decrease in red blood cell count, or a combination of other factors. So the decrease in oxygen leads to less energy being produced in all cells, compensation mechanisms to try to improve oxygen supply, tachycardia, vasoconstriction of the periphery. It can also produce fatigue, pallor. What's pallor mean?
I don't know. What does that mean?
That's the pale skin color. Dyspnea, difficulty breathing. Decreased regeneration of epithelial cells cause the digestive tract to become inflamed, potentially ulcerated. And then hair and skin might show degenerative changes as well. Severe anemia can cause angina, which is chest pain with exertion. So there's a few different types. Iron deficiency anemia, which impairs the synthesis of hemoglobin. Megaloblastic anemia, which, as the name implies, obviously, are characterized by very large immature nucleated erythrocytes. So if you didn't get that through the name, come on, we got to just slow down and start paying attention. That's what the textbook said, as the name implies.
I thought you were making that up, and I
No,
was
am I that kind of a jokester?
Whenever I hear megaloblastic, that's not what I would think.
Well, look it up in the dictionary. It means large immature nucleated erythrocytes.
Wow.
Typically because of folic acid or vitamin B12 deficiency. Aplastic anemia as a result of impairment in the bone marrow. Again, where the bone marrow is where the red blood cells are being produced. So if we're not producing the red blood cells, then we're going to have an anemia because of that. And then there's also sickle cell anemia. This is an inherited genetic disorder characterized by abnormal shape of hemoglobin. Survival rates have improved from 20 years old to around middle age for patients today. We have some different blood clotting disorders. So spontaneous bleeding or excessive bleeding following minor trauma indicates some sort of blood clotting disorder. Excessive bleeding can be caused by acute viral infections, chemotherapy, defective platelet function. Again, those platelets are designed to help clot blood. Vitamin K deficiency, liver disease, or anticoagulant drugs can also be an important factor that would create that. So the three major blood clotting pathologies we'll talk about: Hemophilia A, von Willard's disease, Willebrand's disease, and Thrombophilia. So do you want to talk about hemophilia?
Yeah, I do. So hemophilia A is a deficit of a clotting factor 8, and it's the most common inherited clotting disorder, which we mentioned. It's an X-linked recessive trait, so women can be carriers, but men manifest it. So you won't see women who are diagnosed with hemophilia A. There are other types of hemophilia, but type A is about 90% of the cases. And the other types include hemophilia B, which is also known as Christmas disease, and hemophilia C, which is Rosenthal hemophilia. So there's around 18 to 20,000 cases in the US. 400 newborns in the US are born with hemophilia, and it can range from mild to severe. So around 70% of people have the severe form. And so that's the 1% of factor 8 activity having less. So signs and symptoms and treatment of hemophilia. Signs and symptoms is a prolonged or severe hemorrhage after minor tissue trauma, persistent oozing of blood after minor injuries, spontaneous hemorrhage into joints, so hemarthrosis can occur, and it may eventually cause painful and crippling joint deformities from recurrent inflammation. And then the blood can appear in urine or feces because of bleeding in kidneys or the digestive tract. Treatment involves medications to raise the clotting factors, clotting factor replacement therapy, but there can be a risk of infections, and some people develop immune reactions to the replacement therapy. And then there are new medications being developed that include things like gene therapy. Precautions. So there's lots of precautions, if you can imagine, with hemophilia. Using caution with treatment prior to surgery or dental procedures. So in these cases, they may do infusions of clotting medication that last for a certain number of hours to get them through surgery or procedure. So personnel should be ready with supplies for emergency, and that includes dressings, application of pressure to wounds, and then cold dressings. Why cold dressings?
Vasoconstriction.
So, and rehab medicine, so what we're looking at when we have someone who has hemophilia is we want to use caution with contact. So that includes all manual and massage techniques. Working on balance training, why would that be important with hemophilia?
Well, if we can prevent a fall, because if our patients fall, they will have a major bleeding event. And whether the skin is broken or not doesn't matter. If the skin is broken, now they're losing blood, and it's a life-threatening problem. Just a simple fall can become life-threatening in a blink of an eye. But even if there's no broken skin, we can get these hemiarthrosis where there's bleeding within the joints. So yeah, education on our patients on activities. How do we stay away from activities? What exercise should we stay away from and should not, to prevent these bleeding episodes?
And even from an occupational therapy perspective, looking at how, if you see hemophilia in someone's chart that you're treating, and you're working on ADLs and IADLs, you may need to look at, how are they brushing their teeth? How can you adapt so that they're not cutting their gums when they're brushing their teeth? Maybe you're working on increasing independence in the kitchen. So, if a person has hemiplegia, you really have to look at how can you help prevent. You're looking at both of the diagnoses and considering them together. How do you keep the person safe while you help support increasing their independence in those activities?
Yeah.
And with having comorbidities, one example that I have of hemophilia is I had a patient who had Hemophilia A, and it was severe. He also had a seizure disorder. He had epilepsy, and he would have drop seizures.
Jeez.
And on top of that, he was HIV positive. So with all of those diagnoses together, we had to be very, very careful.
I don't know if there's 3 conditions that I'd like to have in combination less than those 3. That is something. Wow.
Yeah.
I think it's important for us to consider, I know our textbooks and our slides say any contact with a patient, including all manual and massage techniques, should be careful. There's plenty of techniques that we have that can cause bruising type events in our otherwise healthy individuals. People without hemophilia, it can cause bruising. Instrument aided massage techniques, Graston techniques, or even things like cupping, that's pretty popular, where that's going to cause mild bruising in most patients. Well, with our patients with hemophilia, it's going to cause severe bruising or bleeding events, even at a light contact level. So really, really looking at our modalities and our hands-on treatments and being extra cautious with that is really important.
And I think just not relying on the precaution or contraindication for hemophilia to be something that you've studied specifically or come across with each technique or any equipment that you might use. And just if you see hemophilia, anything you're thinking of doing, maybe just double check and make sure.
Yeah. I mean, everything from modalities, hands-on techniques, and exercise. Yeah. I think the one green light is balance training done safely. I think that's the one green light we have. Everything else should be a good question. Yeah. Do you know anything about von Willebrand's disease?
I do know about von Willebrand's disease. I actually have von Willebrand's disease. I was diagnosed when I was about 18 years old after I had my wisdom teeth removed, and they said I bled a lot when I had my wisdom teeth removed, and then they tested me for von Willebrand's disease, and it turns out that I have it. It's a very mild form. It just means for me that if I have to have any type of surgery or procedure, then I have a special medication beforehand to help my blood clot faster. And so it's a hereditary blood clotting disorder. This one, obviously, you will see in women, and is caused by a deficiency of the von Willebrand's factor. And it helps platelets clump together and stick to the walls of the blood vessels. So it can be difficult to diagnose because the von Willebrand's factor will increase if there's any type of inflammation in the body. And unfortunately, a lot of the time when people do go to the doctor, they are going because there's some type of inflammation. So when they get tested, their von Willebrand's factor will be higher. So that's for the more mild versions. Signs and symptoms are similar to hemophilia, but generally much milder. There can be skin rashes, there can be nosebleeds, easy bruising, bleeding of gums, and abnormal menstrual bleeding. It can also be so mild that people don't notice unless they have some type of a surgery or something, which is the case with me. And so treatment based on a subtype of von Willebrand's disease. So there are different subtypes. There's, more mild types and then more severe types. So the same precautions as hemophilia, medications that involve clotting factors and different hormones to stimulate a release of clotting factors. An interesting thing is that when women are pregnant, their von Willebrand's disease can sometimes go away during their pregnancy because it will raise those factors. So that's the hormonal influence on the clotting factors. And then in
It's a
rehab,
good reason to have just a lot of kids.
yeah. I guess that's one treatment option.
Yeah, kids all the time.
Yeah, you should be a specialist on von Willebrand's.
I have a friend who has 11 kids.
Wow, I had a patient once who had 19 kids.
That's a lot of kids. Just they have von Willebrand's?
No, I
Too
mean,
bad.
of course she didn't.
Yeah.
She was pregnant or nursing her whole life.
Yeah, right. Yeah.
But I'll tell you, when she ended up having to go into subacute rehab and in a nursing home, she had a lot of family involvement.
Yeah.
She had a great team. So anyway, so back to von Willebrand's disease. So in rehab medicine, it's the same as with hemophilia. You want to use caution with contact. So that's all manual and massage techniques, balance training, and then education to decrease bleeding episodes, especially hemarthrosis. Again, that's the bleeding into the joints.
I'll take over for thrombophilia. So it's a group of inherited or acquired disorders that increase the risk of developing abnormal clots in the veins or arteries. So inherited thrombophilia is a result of mutations in the genes responsible for producing coagulation proteins of the blood. Acquired occurs commonly after events like surgery or something else that will allow for increase in clotting factor in the blood or an accumulation of antibodies. So the signs and symptoms are non-specific, and it can affect any organ of the body, any organ or system. If the clot lodges in the heart vessels or in the lungs, it can cause a heart attack or a stroke. So very serious problem. So we can treat the causative condition in the acquired cases, or we can treat with anticoagulants like warfarin, also known as Coumadin. Precautions must be understood when the patient is using medications like anticoagulants, because there's now a risk of excessive bleeding. So the anticoagulants are given to the patient to decrease the risk of blood clots. However, there is a counter risk of the blood becoming too thin, and now we're having excessive bleeding. So careful screening for presence of blood clots, diet education on medications like Coumadin. So for patients, and Coumadin and warfarin I use interchangeably. They're the same drug. So vitamin K can make warfarin and Coumadin less effective. Others will increase the risk of bleeds, like grapefruit, cranberry juice, and alcohol. So having good diet education is really important. And I've had patients who've been on Coumadin for years and didn't understand why things like salads are really tough to eat, because that's going to increase the vitamin K intake and then cause their medicines to be less effective. So, always making sure we're educating our patients. Patients been on Coumadin for years, yet nobody's told them that the salad that they're eating on Thursdays are making that less effective. So always educate your patient. Even if they've had something for years, you might be the first person to talk to them about that. Arteriosclerosis is just a general term for arterial changes, best applied to degenerative changes of the small arteries and arterioles, common in adults over 50, and especially if they have diabetes. So the artery walls loses elasticity, becomes thick, hard, lumen narrows. That's the space in the blood vessel becomes narrowed and may become obstructed. leads to diffuse ischemia, decreased blood flow, decreased oxygen, and potentially necrosis, that's tissue death. So necrosis in the tissue, including the brain, kidneys, and heart. Things I'd like to not have necrosis. So the peripheral vascular disorders and arteriosclerosis. So peripheral vascular disorder, peripheral vascular disease is just a broad term to talk about any abnormality in the arteries or veins outside of the heart. Coronary artery disease is the same classification, just we're talking about the blood vessels within the heart at that point. So arteriosclerosis is differentiated by the presence of atheromas. Those are plaques consisting of lipids, cells, fibrin, and cell debris. The atheromas are formed typically around large arteries like the aorta, carotid, iliac, or coronary arteries. So the process of the pathophysiology of atherosclerosis is, first up, the endothelial injury occurs within the artery. Again, the inner lining of the artery itself should be smooth, but there's some sort of injury that occurs to it. The injury causes inflammation in the area. That inflammation causes cellular damage. White blood cells and lipids start to accumulate in that inflammatory area. Smooth cells proliferate and multiply. The plaque is formed by the cell accumulation and inflammation persists. Then platelets start to adhere to now the rough damaged surface of the wall. That forms the thrombus, which begins to partially obstruct the artery. Lipids, over time, lipids continue to build up along the site of the injury with that fibrous tissue, which causes more inflammation, more vasospasm, and more platelets are drawn to the site and enlarges that thrombus, which narrows the artery more and more. So this is a long process that starts with a simple endothelial injury, but because the lining of the artery is no longer smooth, all of these other substances can start attaching to the cell wall and then causes narrowing of that artery. At some point, plaque, the buildup of that plaque, a piece of it might break open, which will cause more inflammation and more growth. The atheroma also damages the vessel wall and could lead to an aneurysm, which we'll cover in a little bit. Blood serum high in low density lipoproteins is an increased risk to this process. The LDL is cholesterol that is considered the bad cholesterol. If we can increase our good cholesterol, which is the high density lipoproteins, that will lower the risk of this process. So knowing your blood cholesterol count is important. So signs and symptoms include, first, increasing fatigue and weakness in the lower extremities as blood flow decreases. Intermittent claudication is a key indicator. So intermittent claudication is a deep pain, ache, cramping type sensation in the calves with activity, and rest relieves this discomfort. So what's happening? What's that?
Back to the first bullet.
What?
No, the first bullet.
The increasing fatigue and weakness.
You're saying that they will have okay, they will have increasing fatigue and weakness. Okay.
Yeah, my legs feel tired. My legs feel
okay.
weak. My legs, my legs feel like jello. I feel like my shoes are made out of cement. Those are all common complaints.
I see. Okay, I heard that wrong. Sorry to interrupt.
No, that's okay. Important. So the intermittent claudication, that deep pain and ache relieved by rest. So what's happening is the blood vessels that are designed to bring good nutrients to the working muscles, when we do things like go for a walk, go up and down stairs, that creates the increased deep ache, that intermittent claudication. What we're doing with the activity is we're increasing the demand of oxygen. However, because of the narrowed artery, the supply cannot keep up with the demand. And that's what's going to create that discomfort. And that's why once we rest, once we sit down and don't do that activity anymore, the demand is lowered, and then we don't have those sensations anymore. Potentially sensory impairments like paresthesias, tingling, burning, numbness, potentially that can happen. Pelor or cyanosis of the skin while the legs are elevated. So if the artery is already having trouble delivering blood, especially to the feet, this problem becomes more and more pronounced the further away from the heart you get, because there's there's less and less blood flow to that area initially, just because we're so far away from the heart. So if we elevate the legs, the skin color can turn either really pale or bluish tint. The reason is because if the blood flow is already having trouble getting through the narrow artery, if now that blood also has to fight against gravity because of that, that's why we get the decreased the skin color in the decreased coloration of the skin while we're elevated. Could also have increased in redness or rhubarb when in the dependent position. And again, that's gravity dependent. That's legs on the floor, sitting in a chair with the legs dangling, things like that. For our skin screen, the skin will look dry. Again, not enough nutrients to the cell tissues. That's all we're talking about. Hairless, toenails could be thick and hard, always complaining of cold feet, and it would be cold to the touch as well. So the treatment: increase your HDL, lower your HDL cholesterol markers, platelet inhibitor medication to reduce the thrombus formation. Smoking cessation is important. A progressive exercise program. So for people who have intermittent claudication, we would exercise to the point of mild claudication, then rest. So let's say that intermittent claudication is brought on after 100 feet of walking. Well, we can do 85 feet of walking, start getting mild symptoms, take a rest, and then we can progress that over time so that intermittent claudication takes longer and longer to start happening. Eventually, it'll come on at 200 feet or 500 feet. So progressive exercise is important. Education of leg positioning. Crossing the legs will decrease blood flow as well. So does leg elevation. So, educating our patient to stop crossing their legs, really tough to do if that's a habit that you're into.
Everyone's changing their leg position right now who was sitting with their legs crossed.
Yeah. Peripheral vasodilators like calcium blockers could be helpful. Maybe some surgical procedures to have bypass grafts, angioplasty, endarterectomy. Pronounce that correctly for me.
Endarterectomy.
So that's removal of the blood vessel lining and obstructive material. So these are all things just to either the bypass graft, we say, okay, this highway's closed down, put a little loop around it and we'll be okay. We'll be able to transfer blood around this thrombus instead of through it. The angioplasty basically just tries to squish the thrombus flat to allow more blood flow through. And potentially amputation especially if there's a gangrenous area. So typically it starts in the toes and then can work progressively from there. So our rehabilitation medicine, the guidance is gradual exercise progression, education on skin screening, because if they have poor circulation, if they have poor delivery of good nutrients and poor removal of wastes, if we do get a skin lesion of some kind, the potential for healing is way less. Avoiding skin breakdown. And the big thing we have with our patients is we have to be really careful of space heaters in particular. And space heaters are so common because one of the signs and symptoms are cold feet. So they have cold feet. They grab the space heater, put it in front of them as they're watching, Maury Povich on TV. But that can create a burn. And if they create a burn, now we have low healing potential because we have limited blood supply to that area. So really big concern with space heaters. Also walking with bare feet for that wound protection. Different massage positions and techniques can help improve blood flow as well. So something to consider if someone has intermittent claudication is an early warning sign. So if you have somebody with these diagnoses, or if you hear of intermittent claudication with our massage students, question what positions do you want to promote, what techniques do you want to do. Potentially you could be delivering more more blood to the area, so that could be something that you consider in the massage world. What do you know about aneurysms?
Okay, aortic aneurysm. So it's a localized dilation and weakening of an arterial wall. The most common location is abdominal or thoracic aorta, and there are different shapes of aneurysm. So you'll see in the image, it's a great image of the different shapes. So there's the saccular shape, and that's where there's bulging on one side. That's the picture all the way to the left. And then the fusiform shape is a circumferential dilation. And then the dissecting aneurysms develop when there's a tear in the intima, allowing blood flow to travel the length of the vessel between the layers of the arterial wall. So etiology, signs, symptoms, and treatment of aneurysm. So it's caused by atherosclerosis, can be caused by trauma like motor vehicle accidents, can be caused by syphilis and other infections, or congenital defects. Congenital, again, means that it happened either during birth or while they were growing as a fetus. Hypertension is present in half of patients with aortic aneurysms. So signs and symptoms is frequently asymptomatic for a long period of time until very large or rupture. Abdominal aneurysms are sometimes detected as palpable masses with abnormal sounds, so they're listened to with a stethoscope. And rupture occasionally leads to moderate bleeding, but most lead to severe hemorrhage and death. Treatment of aortic aneurysms is maintaining blood pressure at a normal level, avoiding sudden elevation of blood pressure like exertion, stress, coughing, or constipation, and then surgery to repair or replace with a synthetic graft that can prevent the rupture. So in rehab medicine, we're going to be aware of the signs and symptoms. And again, that's because we are, even though we don't make diagnoses, we are a part of a diagnosis process. The information that we observe and that we document and that we report can help to identify some of these things that could be happening with our patients. So being aware of the signs and symptoms, and then measuring and maintaining blood pressure. So you would want to be doing a lot of blood pressure, checking blood pressure with these patients.
Thrombophlebitis and phlebothrombosis are terms used often interchangeably. They are a little bit different. So thrombophlebitis is an inflammation in a vein that leads to the development of a thrombus or clot. Phlebothrombosis is a thrombus formed spontaneously without prior inflammation, although inflammation might occur after that thrombus forms. The clot is less firmly attached in this case. So I've always used these terms interchangeably. There is some slight differences in how they start though. So the pathophysiology, several factors predispose thrombus development, stasis, so sluggish blood flow, endothelial injury like we just talked about, and increased blood coagulation can happen because of dehydration, cancer, pregnancy, or increased platelet adhesion. Signs and symptoms often unnoticed until the pulmonary embolism occurs. So in superficial veins, signs and symptoms include aching, burning, tenderness of the affected area. Veins might be inflamed, warm, swollen, or red. Deep vein thrombosis occurs mostly in lower extremities, call those DVTs. Aching, pain, tenderness, and edema located in the lower extremity as blood pools distally to the blood clot. Positive Holman signs is talked about. That's where we squeeze the calf and it hurts. Although that is a really poor test, we might as well flip a coin to see if, the coin tells us if they have a blood clot or not. Much better is the Wells clinical prediction rule. It's a series of, I think it's 7 questions, yes or no questions. If the patient answers yes to more than one of them, there's a high risk for blood clots. So we can look at that. That's a good one. Other signs, systemic signs like fever, malaise might be present. So treatment includes preventative measures such as exercise, elevation of lower extremities, really trying to prevent these blood clots from happening in the first place. Potentially compression stockings, anticoagulant medications, maybe surgical interventions. For us, it's recognizing the signs and symptoms of blood clots early, especially with that Wells clinical prediction rule. This is a life-threatening condition. So if we see signs of it at all, even if we go, oh, I wonder if, requires prompt hospitalization, requires quick evaluation. Anytime I've been worried about a blood clot, I call the doc and the doc says, send them here right now and I'll look at them. So this is a high priority for everybody. All right, there we go. Any closing remarks?
That was so much fun.
Yeah, good, good.
I always have great closing remarks.
All right, we will.
How about you?
I had a blast. Yeah.
Right.
All right. We'll catch up soon. Okay.
All right.
All right. Bye.
See ya.